Well friends, now we'll see pyogenic liver abscesses. First we'll see etiology. Most of the times etiology is unexplained in majority of the patients. It has increased incidence in elderly people, diabetic people and the immunocompromised patients. About 50% of abscesses are solitary with varying sizes. They usually involve right liver lobe. We'll see what are the routes of spread of infection to the liver. Commonest is the spread along the bile ducts after either stone is impacted in CBD or with the CBD stricture. This is the most important spread because if you are asked which of the following forms the most common spread of organisms to liver abscess or which of the following route is most common to form liver abscess, this is the answer. Or it can spread via portal vein or via hepatic artery. The hematogenous spread from the distant site such as colon, pancreas and pelvic inflammatory disease is also seen. In colon especially seen after diverticulitis or appendicitis or after pancreatic inflammation such as after pancreatitis, the organisms can spread to the liver. Liver spread can occur by direct extension from adjoining organs such as seen after cholecystitis if gallbladder ruptures and forms empyema. If empyema is formed and it ruptures, then it can involve adjacent liver. Or by external trauma such as by penetrating trauma, it can spread to the liver. So among all these routes, commonest is the spread along bile ducts after impaction of stone in CBD or lower CBD stricture, may it be benign or malignant. We'll see clinical features. Patients who usually present with anorexia, fever and malaise accompanied by right upper quadrant discomfort. Fever is the most common presentation. We'll diagnose it with ultrasonography, which will show multiloculated cystic mass with debris or with varying echoes in the cavity. CT scan will give the anatomical position, orientation and exact location if it is required to be drained either by intervention, which is maybe by external drainage to pigtail, or through laparoscopy. Abscess is confirmed by aspiration for culture and sensitivity. So once you diagnose it is containing hypoechoic or abscess in the liver, it is further diagnosed with the needle aspiration. Mind well, you should have ruled out hydrated cyst of the liver before aspiration based on sonological criteria. Laboratory investigations will show abnormal LFTs, abnormal liver function tests like alkaline phosphatase and transaminase are mildly elevated. Bilirubin is elevated in most of the patients. If liver function tests are grossly deranged, it will suggest underlying biliary pathology. Liver function tests are mildly elevated. So if associated with the liver abscess, the liver enzymes are grossly deranged, then they will indicate that along with the liver abscess, patient has also got biliary pathology like obstruction, maybe because of various reasons. Serological tests are not helpful in pyogenic abscesses. What are the most common organisms? Streptococcus milleri and Escherichia coli. These are the most common organisms. Other enteric organisms like Streptococcus faecalis can also be seen. Klebsiella and Proteus vulgaris also occur and mixed growths are common. Opportunistic pathogen include Staphylococci. What are the various complications of pyogenic liver abscesses? They are spread to diaphragm, pleura, skin and pericardium. When they rupture in pericardium, they will cause pericardial tamponade, or if ruptured in diaphragm, they will cause empyema and hamper the breathing of the patient. If they rupture in the peritoneal cavity, they can cause peritonitis. Such patients may require laparotomy or laparoscopy depending on the situation. Endogenous endophthalmitis is seen in Klebsiella hepatic abscesses in about 3% of cases. This endogenous endophthalmitis is commonly seen in diabetic patients. What are the treatment choices? Antibiotics are given and ultrasound guided aspiration is done. So any patient who is suspected of pyogenic liver abscess is first started with antibiotics. The first line of antibiotics to be used are penicillin along with aminoglycoside and metronidazole. Also you can use cephalosporins and metronidazole. Ultrasound guidance is taken for percutaneous drainage via pigtail catheter or by repeated aspiration with wide bore needle. As an empyema may follow drainage if it is done through pleural space, Care should be taken not to traverse pleural space. Origin of liver abscess should be sought from where this source has come to the liver, and particularly from colon or after appendix or after appendicitis. So origin of the bacteria should be tackled along with the treatment of the hepatic abscesses. Or typical clinical presentations like absence of fever or toxicity or absence of typical radiological findings should raise the possibility of necrotic neoplasm. So many times if the growth is there in liver, if it undergoes necrosis and liquefaction, it may mimic liver abscess. So absence of fever and atypical presentation on radiological investigation should arouse the suspicion of malignancy. Sometimes if abscess gets ruptured in the peritoneum, it should be drained either by laparoscopy, or if it is loculated, you can still drain it with pigtail catheter. So friends, now we'll see amoebic liver abscesses. We'll see how these abscesses occur in liver. Entamoeba histolytica, it is a causative protozoon and it exists as trophocyte or as a cyst. Whenever cysts of Entamoeba histolytica are ingested, the intake is through fecal-oral route. So after ingestion of the contaminated water or vegetable, Entamoeba histolytica cyst, after ingestion, the Entamoeba histolytica cysts who are not degraded in the stomach, they pass on to the intestine, where the trophozoite is released and passed on to the colon. In the colon, trophozoite can invade mucosa and result in disease in liver through portal venous system. So once this trophozoite reach in the liver through portal venous system, they cause release of various enzymes. This will cause necrosis of liver parenchyma. So whenever liver parenchyma undergoes necrosis, it will induce inflammation and aggregation of neutrophils can occur. So all these features along with necrosis will form a typical nature of the pus, which is called as anchovy sauce. So this necrosis is seen typically in liver parenchyma. So whenever these abscesses reaches up to the level of the peritoneum covering the liver, the peritoneum being resistant to trophozoites, it resists digestion. All these abscesses are limited by liver, that is visceral peritoneum of the liver. So this anchovy sauce of the pus is odorless unless secondary bacterial infection takes place. The typical clinical picture of the patient who is aging from 20 to 40 years, has traveled an endemic area, presents with fever, chills, anorexia and right upper quadrant pain, and patient may have tenderness along with hepatomegaly. The abdominal pain is typically constant, dull aching, localized on the right side of the abdomen. Jaundice as a result of the large abscess compressing the biliary tree is a rare presentation. Pleuritic or shoulder pain can occur if this abscess irritates the diaphragm. This is the referred pain to the right shoulder. Now we'll see what are the laboratory abnormalities. They are common in amoebic abscesses. Patients typically have mild to moderate leukocytosis with or without eosinophilia. Mild abnormalities of liver function tests including albumin, prothrombin time, ALP, AST and bilirubin levels are typical. The most common liver function abnormality is an elevated prothrombin time. So if you are asked a question, which of the following forms the most common abnormality seen in amoebic liver abscesses, it is the prothrombin time which is deranged. Because greater than 70% of the patients with amoebic liver abscesses do not have detectable amoebae in their stool, the most useful laboratory evaluation is the measurement of circulating antibodies against the Entamoeba histolytica. They are measured by immunoassay. We are present in 90 to 95% of the patients. So this test is positive in 90 to 95% of the patients. Although these amoebae reach from colon to the liver, in most of the patients, typical history of loose motions or diarrhea may be absent. The cultures of the amoebic abscess are usually negative. They may become positive only after secondary infection with the pathogenic bacteria, which will show microorganisms on the growth culture. So typically if you send pus, it won't show trophozoites. But sometimes if the periphery from the abscesses is taken, it may show trophozoites in the abscess. Radiological studies will show on plain X-ray chest. Radiological studies will show following things. Plain X-ray chest is abnormal in half of the cases, showing elevated right dome of the diaphragm along with the pleural effusion or associated atelectasis. Abnormal abdominal ultrasound has reported accuracy of 90% when combined with typical history and clinical presentation. Only abdominal ultrasound may not be that sensitive, but if it is combined with clinical presentation and typical history, it may reach or it may clinch the diagnosis in 90% of the patients. Abdominal CT scan is the most sensitive than ultrasound and helpful in differentiating amoebic from pyogenic liver abscess. So this is very important point. So if you are given various options, which of the following is the most sensitive? So it is the CT scan. MRI of the liver has no distinct advantage over CT or ultrasound in typical cases. But in atypical cases, when there is suspicious of tumor necrosis leading to the liquefaction, so this is helpful in differentiating from amoebic liver abscess. So MRI is helpful differentiating necrosis in tumors from amoebic abscesses. Nuclear medicine studies such as gallium scanning or technetium-99 liver scans are helpful in differentiating pyogenic from amoebic abscesses because the latter typically do not contain leukocytes and therefore do not light up on the scan. So pyogenic liver abscesses will have leukocytes and amoebic liver abscesses would not have leukocytes. So on nuclear medicine or gallium or technetium scan, the amoebic liver abscesses would not light up. How do you manage amoebic liver abscesses? The mainstay of treatment in amoebic liver abscesses is metronidazole, which is given 750 milligrams orally 3 times per day for 10 days. Or in severe cases, metronidazole can be given intravenous routes. Most of times, around 90% of the patients are cured by this. Clinical improvement is usually seen in 3 days. Also, other nitroimidazole group drugs like sectinidazole or tinidazole can also be used. They are as equally effective as metronidazole. In general, aspiration is recommended when following things can be seen. For failure to respond to the metronidazole therapy in 3 to 5 days, you can resort to aspiration. Or in liver abscesses, they are believed to be high risk for rupture. Generally, if the size is more than 5 cm, the liver abscess is high risk for rupture, along with if it is located very near to the visceral peritoneum or liver capsule. So these cases, usually when present on the left lobe, they are likely to rupture in the pericardium. So these abscesses should be tapped as soon as possible. The most frequent complication of amoebic liver abscesses is rupture in the peritoneum, pleural cavity or pericardium. Size of the abscesses is the most important risk factor for rupture. So if you are asked which of the following of the abscesses forms the most important risk factor, they may give you choices like size of the abscess, location of the abscess and duration of the abscess. It is not all this, but only the size of the abscesses will form the most important risk factor for rupture. So even if it is located deeply, size of the abscess, if it is small, it won't rupture, but if it is more larger, then it is likely to rupture. Laparotomy was advocated in the past for this complication, but nowadays many cases can be managed percutaneous drainage. So if you are asked which of the following forms most important management for ruptured liver abscess in the peritoneum, don't just jump to that laparotomy because it was advocated earlier. But nowadays the recent evidences show that most of these cases can be managed percutaneously by inserting of drainage catheter. So this is very important point. So friends, we saw today various abscesses, either pyogenic and amoebic liver abscesses and their management along with their complications. Thank you.